All right, good morning. I think we're going to get started. I want to introduce our speaker today. So our speaker is Dr. Tim Atterbury. Dr. Atterbury is the CEO of the American College of Cardiology. I've been fortunate to get to know him over the past year since he joined as the CEO last fall. Dr. Atterbury has had a very long career in healthcare as an executive, almost 30 years in the cardiovascular service line as an administrator or as a CEO. And now he joined the ACC last fall. I think Greg and I talked about this earlier this year, that I think one of the things that in moving forward with Grand Rounds that I think is exciting is to come to a program that is a little bit different than what we're accustomed to. And one of the things, in fact, with many of our fellows and trainees is what is cardiology care going to look like for your futures? And with a lot of the instability and turbulence that it's going on in academic healthcare systems and others, including our own sort of transformation with bringing Northwest Hospital as part of our UW enterprise, I think this is really a timely presentation. So Dr. Atterbury, thank you for coming today.
Thanks, Dr. Yang. And my doctor is not anything clinical, so I'm not a real doctor in this room, but I appreciate that. I can talk about my dissertation later if you want, about hospital mergers and what that means for patients and consumers. That's a whole other point. Thanks for the invitation, and Erica, wherever you are, thanks for helping me get everything set up and then well taken care of. Thank you all for coming out. As Eugene said, this is not a clinical talk. I'm going to give you a different view of the world. So if you'll indulge me, I'll just plow in. We'll save questions for the last part of the presentation. I think we've got about 15 minutes of Q&A. Nothing to disclose. And here is the outline. I must give you an ACC update. I'm the CEO of the ACC, so my board requires me to give you an ACC update / commercial. So I'll do that very quickly, then we'll move on to the presentation. So here's our new strategic plan for the ACC. When I started last fall, September 2018, we were just wrapping up the strategic planning process. So we have our mission, vision, values. The mission statement has been around a while. I love the mission statement. I love the vision statement. The mission statement has a key word there. That's transform. I think that's core to the ACC. We believe that the way we deliver cardiovascular care in the US and worldwide needs to be transformed. Transformed, not a little tweaking, but something more transformative, some substantial change in care models, care delivery, and how we're paid for care. That's going to be a big part of what I'm going to be talking about over the next few minutes. Then, of course, the vision statement, the big statement there is a world. So the ACC, the first word in our name, is the American College of Cardiology. But for years, we have been pursuing an international footprint. The board decided about 6 months ago that we're going to accelerate our footprint worldwide. We already have 42 chapters outside the US. We're accelerating that. 17,000 of our 52,000 members are outside the US. We believe that cardiovascular disease is a worldwide problem. It's the #1 cause of death worldwide, even in Africa. It's the #1 consumer of healthcare resources in every country. And to the extent we don't manage cardiovascular disease efficiently well, then each country is having to deal with that burden. So I was in China about 6 months ago meeting with the Ministry of Health, and they said, Tim, the cost of cardiovascular disease in China is unsustainable. We can't continue to spend all we're spending on cardiovascular disease. Sound familiar? That sounds just like the US or Germany or some other countries. So this is a worldwide issue. So the ACC owes it to our members and owes it to cardiovascular clinicians and leaders worldwide to have solutions. And those solutions need to be both clinical solutions and non-clinical solutions. We need to have ways of not only improving the quality of care, but also, as you'll see, a theme of my presentation here, the efficiency of care. Then on to the right, we have our 4 major goals. So let's tie it all together. We believe that there's a better way to provide care delivery. Let's equip that better way with actionable knowledge. Let's make sure that everybody feels comfortable in the ACC as their professional home. Cardiologist, nurse practitioner, PA, PharmD, Ecotech, Cath Lab Tech, RN, you name it. Everybody needs to be at home here. And we know this is a team sport. This is cardiologists and the team working together to deliver the services. So let's make sure everybody feels at home in the ACC. And then last, if we do that well, the organization will be sustained. We'll be around another 70 years. We're celebrating 70th year anniversary this year, 2019. I'd like to make sure that the ACC is around for 70 more years. We've distilled our strategic plan into two basic comments, two basic statements. One is preserve the core. The ACC is a great organization. It's wonderful. It's got a great history. Let's preserve the core things about the ACC, educational products, guidelines, consensus documents, all the things that make the ACC great. Let's preserve them. However, what we have identified, what the board has concluded through the strategic planning process, is that alone, those core services alone, will not sustain the ACC. We could become the incredible shrinking ACC if we only provide the core services, the core products. We need to expand what we do. And the expansion occurs in what we're calling the frontier, the new areas that the ACC needs to explore to identify ways that we can add more value to you as members and to the health systems that are represented by those members, to make sure we're continuing to be relevant. Otherwise, members may decide not to be a member. Health systems may decide not to purchase the NCDR registry to look at quality. They may look at other options. And we do not want to be the incredible shrinking ACC on my watch, so we want to continue to push and explore that frontier. And then lastly, on the strategic plan over here on the right are the 4 strategic imperatives that we've identified for the ACC. You may be familiar that over the last 10, 12 years, and I've watched it happen, a big landscape change in cardiology in the U.S. 75 to 80% of cardiologists in the U.S. currently work as employees of a health system. If you go back 12 years ago, that was probably about 15%. So we've had a huge uptake in the number of cardiologists who are employed by health systems. You can look at that as positive, negative. We're going to save that for another grand rounds. I'll come back in here, we can talk about that. But they're there. There has been a structural change in the way care is delivered. Cardiologists are inside of health systems, number one. Number two, the health systems are getting bigger. We know that health systems are consolidating. Hospitals are merging. Health systems emerging. Big health systems are buying small health systems. So now we find health systems as a big unit of delivery inside of cardiovascular services, inside of healthcare. What's the ACC's relationship with health systems? Well, quite frankly, we've not developed relationships with health systems. Our relationships have been with individual members, and we've sold NCDR as a service to health systems, but we haven't really connected to those health system leaders the way we need to. So part of our strategic plan is to connect with health systems, big and small, in order to make sure that we're relevant to the C-suite and to the leaders of the cardiovascular services inside those health systems. The digital transformation just refers to the fact that we set on a lot of knowledge. That's the ACC's big asset, is we have a lot of knowledge. We have a lot of information that is stored inside the ACC around guidelines, clinical consensus documents, etc. Unfortunately, we haven't digitized and delivered that knowledge in a way that it impacts or is available at the point of care seamlessly. We're looking for ways to do that. I do not have all the answers there. I'd like to hear from you about maybe ways to do that, but we want to make sure that everything that's called knowledge inside the ACC is available to you without having to go to a website or worse yet, pick up a 3,000-page guideline document or the 100-page executive summary of the guideline document and start flipping through it. Actionable knowledge means it needs to be available in a format that's inside of your workflow, and you can immediately access that knowledge. Otherwise, the knowledge doesn't have much value. All right, so enough about that. Let's talk about the U.S. healthcare problems. We're going to focus for the next few minutes on describing the problem we face as a nation with healthcare. And you've seen some of this information, so I don't want to bore you with too much of the details and go through the numbers. But I think it's important to have a foundation, especially for those of you who maybe have never been involved with any kind of healthcare delivery. And by the way, these slides, I told Erica, they're yours. If you want them, you can have them in digital format. You can refer to them. You can take them and use them in a future presentation, or you can throw them away, whatever your wish is. So here's kind of the overall structure of the American healthcare system, really any healthcare system in some ways. You've got inputs. This is just basic business concepts. You've got inputs, people, technology, money, and we put those inputs into the structure and process we call the American healthcare system. You're part of that. And it has different locations of care. It has managed care and health networks all together. Then there's an output. The output to society is maybe some cost, Medicare tax, your premiums, your co-pays, deductibles. You have access issues. You have quality issues. You have happy patients or unhappy patients, depending upon experience. Then we output policy reform concepts. And then the future trends is how do you tie in these things that are on our radar right now, but a lot of people are trying to figure out to improve health in the American population, is it all about the quality of healthcare, or are there other variables involved? And what we've learned over the last 10 years of a lot of research in this area is the quality of healthcare available in a certain population only accounts for about 15 to 20% of the health of that population. The other 80 to 85% are down in what we call the social determinants of health. You probably have heard that term. It's a real issue, but the difference between health outcomes being positive or health outcomes not being positive has less to do with the quality of healthcare or the quality of the individuals involved with healthcare. It has more to do with all those other socioeconomic issues: food, housing, the social infrastructure of the individual. Do they have support at home, etc.? So those are also important factors. And we're learning more about them. Health systems are trying to figure out how do you incorporate that. This one, I love this one. We won't even go through this one. It makes my head hurt when I see this. But this is for 2014, when you say per capita healthcare spending, all of these arrows have the dollars that explains what each of the per capita amounts, that was in 2014, was $9,526 per American. It's obviously higher than that now. But this gives you all the different flow of dollars. You've got the government, which, by the way, in the U.S., about half the population of the U.S. has their health insurance through a government program. Medicare, Medicaid, veterans, military, the Indian Health Service, and the U.S. prisons. So about half the Americans get their health care from a federal government sponsored or supported, funded healthcare program, health insurance. The other half either are uninsured, there's a small number, or they're insured through their employer. So this gives you the flow of dollars. It's a spaghetti mess. There's no doubt about it. This is typical American healthcare system. When we talk about this and compare it to other countries don't have this spaghetti mess the way we do. So we have partially government socialized medicine and partially commercial or employer-sponsored healthcare services. So William Kissick, he distilled this down. He said, when you're designing or developing a healthcare system, there are three things you might be able to get, the golden triangle, from a healthcare system, or even a healthcare episode. You can distill it down to an episode, or on a macro level, the whole healthcare system. So you can have quality, we'll say quality and safety, that's a clinical variable. You can have access, can I get easily in geographically, and the time that I have to wait for that service. And then how much does it either cost me as a person or cost society? So you can break it down in 3 E's. You can have effective healthcare, you can have equitable healthcare, you can have efficient healthcare. Now here's a problem we've learned, is you can't get all three, meaning that you can't have the highest quality at the lowest cost at the easiest access. You can't have it. So countries have trade-offs. In the US, our trade-off is cost. We have great quality. We have pretty good access, actually great access for certain services across the US. If you look at maps of the US, the waiting times for an MR or any other type of procedure is very low by comparison, but our cost is very high. So our effort to cut costs, that's what we're trying to do in the US right now on a macro level, or even inside your health system, you're trying to cut costs. We're trying to deal with the unsustainable rise in healthcare costs on a per capita basis to the economy. How are we going to cut costs? If we cut costs, are we going to reduce quality? Are we going to reduce access? As a nation, if we say we really need to get costs under control, does that mean we may have to lower one of these other two elements? It might. We'll see. Stay tuned on that one, but I think that's what we have to consider. If we want the easiest access and the highest quality, can you actually do that at a low cost? So here's some information about healthcare spending. This is national healthcare expenditures in the U.S. going from 1960 projected out to 2024. This is just total cost to the economy. The total load, if you're looking at this from a macroeconomic standpoint, what's the total load, demand, weight of the healthcare expenditures on the American healthcare economy? So 1960, very low, and you can see from 60 to 80, the trend line is slow growth. Then the 80 to 2000 growth speeds up, and then 2010 speeds up some more, and then the baby boomers start turning age 65 at the rate of 10,000 a day about 7 years ago, and now that's churning through the baby boomers. Obviously, as you get older, you utilize and need more healthcare services. So now we have those baby boomers are moving through the healthcare system, pulling more weight, pulling more dollars into healthcare services. Let's look at this maybe on a per capita basis, because that's just the total. This is where we stand 2018, most recent data. This is from OECD reports, the 29 countries that are considered to be the industrialized nations of the world. So here's a sample of those. We're pretty high on a per capita basis. You could say, well, that's okay because we're a rich country. Our per capita income is pretty high. So let's normalize that, not just per capita spending. Let's look at per capita healthcare spending compared to per capita income. Maybe we're not so bad. So let's see. Oops, not so good. The x-axis is GDP per capita, and this is healthcare spending. So we have 4 countries that have higher income than we do. But look at our healthcare spending here. So we have lower income, those 4 countries, and we have the higher healthcare costs. We're the highest healthcare costs. We're not the highest per capita income. Not a good place to be, but maybe we get more for our money. Maybe that's the explanation. Maybe we may not make it up in our income. Yes, we're spending a lot, but maybe our outcomes are better. Let's just look at life expectancy. Well, not so good. Here's healthcare spending. We're the highest. And there's a bunch of countries that have lower healthcare spending, but better life expectancy. So it's a big problem. We all know that this is a big problem. And why is this happening? Why are we so far out? This has been looked at from a variety of people. I won't go into a lot of detail, but I'm going to simplify it. This is the guy, if you do some research, Uwe Reinhardt, he's passed away a few years ago. He was the guy back in the 90s that did the big research piece and actually kind of put out to the nation this challenge about it's the price is stupid. Meaning that our utilization, if you go back to this, is it utilization or price? Our utilization as a nation of healthcare services is not so much different than the OECD countries, the other 28 countries. There are a few things we're higher on, but that does not explain the difference in this. What explains that high cost? I actually thought errantly for years we were just consuming a lot of service. It's actually not true. Our inpatient days per 100,000, our inpatient admissions are actually lower than most OECD countries. Our utilization of office visits is lower. Our utilization of subspecialty services is about average. Now, we are higher on advanced imaging, and we are higher on advanced medications, pharmaceutical therapeutics. But that higher only explains about 3 or 4% of our difference. What's the other part? Uwe Reinhardt said 25 years ago, it's the prices, stupid. It's what we're paying for these services. That's what's making it the US cost more. Then recently, somebody came out and actually went through another analysis because Dr. Reinhardt passed away. They thought, well, out of respect to him, let's do another analysis updated in 2018. And guess what? Based on 2018 data, it's still the prices, stupid. So we are still paying a lot per unit of service, a lot more than the rest of the world pays for a CT. We pay more to buy a CT. We pay more for the buildings. We pay more for the people who work in those buildings. We pay more for the medication. We pay more for everything. And we pass that more on to the consumer and the insurance companies and Medicare. So it's the prices. So at some point, we got to get prices down in order to make sure we get our healthcare costs down. There are some avoidable costs. I won't belabor this one. I've got some references here to the analysis that have been done. But inside the US healthcare system, a lot of smart economists and smart healthcare experts have looked at the way we spend money, and they've concluded there are some opportunities to lower spending. Forget about price. There are some ways maybe to have better coordination of care, that we could get more efficiency out of the system. Some big numbers here, medium-sized numbers. And here are the categories of how you would get that out. This may give you some insight. All right, if you're the one paying for healthcare services, and you realize there are some avoidable costs inside of healthcare spending, you may look to the people providing the care. Can you help get those avoidable costs out? Otherwise, if the people providing the care can't get those avoidable costs out, they may turn to somebody else, maybe a radiology benefits management company. Ever heard of them? RBMs. That's the people you have to call to get a pre-authorization for a CT or advanced imaging. Or maybe a pharmacy benefit management company. Who are those people? It's the closest thing to organized crime, I think, in the US is the pharmacy benefit management company, because they sit between the patient and the pharmaceutical companies, and they extract their little toll inside them. Those are the people who are saying, I'll deliver some value. I'll try to make this very irrational system more rational, more efficient. My message would be, we should be doing this. All of us in this room should be the ones delivering this value. If we don't deliver this value of making a more efficient system, taking the avoidable costs out, holding ourselves accountable for variations in care internally, for the efficiency in care of how we deliver it internally, and if we don't hold ourselves accountable, then what we're going to see is more and more external parties applying their pressures to us. And I don't think that's going to be pleasing for anybody. So what's the state of CVD services? That was the macro of all healthcare services. What about cardiovascular? Well, we know that cardiology, cardiovascular disease, circulatory disorders accounts for about 20% of spending in the US throughout the entire system, but it's 30% in Medicare. It's the single biggest chunk in all healthcare spending, with the exception of if the covered lives are average age 35, 40 below, cardiovascular services does not comprise the biggest chunk. Once you get to about age 45, if your covered lives are age 45 and older, then cardiovascular disease is the #1 spending for that population. So overall, Medicare, 30% of Medicare spending tied to cardiovascular services. Who is Medicare? It's the federal government. Who's the federal government? It's us, the taxpayers. So we are, through our taxes, we are paying for this service. And what we know about CVD is there's a lot of people with some form of cardiovascular disease. It's a very profitable service line to health systems. Most health systems, big health systems, will tell you, if the cardiovascular service line has a cold, the health system is dying. If the cardiovascular service line is growing and prospering, the health system can cover up a lot of losses elsewhere in unprofitable services. Cardiology, cardiovascular services, big profit maker for health systems. And guess what? Medicare is the biggest payer for most cardiovascular services, most health systems. 55, 60% of your patients inside of a health system are Medicare patients. Medicare actuaries gave a report recently. Medicare will run out of money around June of 2026. At that time, under the statute, Medicare has to lower all providers' reimbursement according to the Medicare tax revenue coming in. That would require about a 30% cut. So if we do nothing as a nation, if we do nothing as cardiovascular leaders, if we do nothing as healthcare leaders, come June of 2026, thereabouts, Medicare will say the revenue we receive every month from Medicare taxes can only pay for about 70% of the current reimbursement. So everybody who's a Medicare provider gets a 30% pay cut. That would be a bad thing. UW would be in trouble. Cardiology would be in trouble. So we are on a train that's heading toward a crash, and that crash is certain, and effort intervention is needed. Otherwise, we'll end up with a 30% pay cut. So here are all the other components of the CVD environment. I would just point out that a lot of smart people, Cleveland Clinic, several big universities have studied the cardiovascular spending, and they've concluded around 30% of what we spend on cardiovascular services in the US could be avoided through better coordination of care, through better packaging of that care, through better post-discharge transition of care coordination, through better disease management. We're going to talk a little bit about that as we go through. So last, I'll just point to this guy. If you've not heard of this guy, you might want to go to Mr. Google, type in Chernu, and get some of his analysis. He has a very keen understanding of the problem we face as a nation. And his recommendations are, if we're going to slow spending, if we're going to get spending growth to be pulled down, we're going to get spending under control as a nation, here are the different levers that we need to pull. And the #1 lever, if you've heard him speak, he will tell you payment reform is the key. If you don't have payment reform, there is no way that you can get the avoidable cost in a more efficient system. It's impossible. You have to align the financial incentives, and we're going to spend some time talking about that. All right, so value-based care, you've probably heard these terms, right? Value-based care, value-based payment. It goes by other terms. Early on, years and years ago, it was called pay for performance. That was an early term. I'm going to pay you, but instead of pay you for volume, I'm going to pay you for performance. Let's face it, for the many, many, many years of the modern American healthcare system, it is a fee for volume system. The more CPT codes you generate, the more money you generate. The more DRGs you generate, the more money you generate. That's the platform of the system. And what that got us is a very robust system with great access where you could get in to see a cardiologist or get in to see go to a hospital, be an inpatient fairly readily. Now it's getting harder recently because of nursing shortages and declining capacity within the system, but still, relatively speaking, it's been easy to get access. So pay for value and pay for performance shifts from pay for volume or fee for volume to a fee for value. So what is value? And here are the different definitions then of value-based care and value-based payment. If you look through these, what you'll see is the term describing some shift that instead of paying for just providing the service, it's providing the service based upon an outcome. So I'm going to link payment to an outcome. I'm going to reward physicians, clinicians, the health system for some health outcome versus just providing the CPT code service itself. I'm going to encourage and reward clinicians for removing cost from the system. I'm going to link payments to the improvement. And finally, I'm going to hold providers accountable. I would look at those statements as there's some risk in the payment. Right now, the risk to being paid is relatively low. Some patients cannot pay, so we take the risk that we get no pay. But if somebody's insured, generally speaking, the revenue cycle inside of the health system is pretty good at turning a DRG, CPT, APC, whatever, into reimbursement. What value-based care says is instead of linking the payment solely to the provision of the episode of care, that one CPT code, we're going to broaden that definition to something else. Let's look at what that something else might be. Here are the different categories of value-based payment, ultimately ending in category 4, which is population health-based. Category 3 is bundled payments. You've heard of that, where an episode of care is bundled over a certain period of time. And then category 2 is really just paying you for reporting, your MIPS, your QPP, et cetera, just to pay for reporting. This is where we're probably going. Now, some people dispute that, so I recognize that. There are smart people in the US that say, we're never going to make a full transition to value-based reimbursement. It's too hard. We're just going to probably continue to be this production-based operation. I don't see it that way. I don't see how it's sustainable that way, but I recognize there's a difference of opinion. I think we are on a certain course to move more and more payment to either a bundle or a population health. The difference between these two, by the way, the bundle is I take an episode, an elective PCI, a pacemaker, an ICD, a CABG, and I wrap around some time period, 90 days, 180 days, or a year, and I pay a fixed fee for all the services associated with that anchor admission. Population health takes it to another level. If you have 50,000 patients that primarily get their healthcare services from UW or 200,000, whatever the number is, just going to pay you a certain amount, capitation, and you're going to take the risk for the health outcomes. Big gap between those two, but you can see in the US there's shifts in populations all around the US with bundling and with population health-based reimbursement. All right, so what is value? When we say value, what does that mean? So we're going to lay a quick foundation of the definition of value. So Warren Buffett, pretty smart guy, pretty wealthy guy. So if you associate wealth with smart, he's a very smart guy. And so he says price is what you pay, but what do you get? You get some value, right? That's a simple economic way of looking at it. I pay $1 for something. What do I get? What utility do I get? That's the value. Michael Porter, who's a pretty smart guy as well, from Harvard, who has talked about healthcare for many, many years, written and published a lot of research. He says it maybe a little more crisply. It's health outcomes achieved per dollar spent. So there's a relationship between some outcome and the price paid or the dollar spent. So now we're starting to see another element here. It's the health outcome. We're using the term outcome. And that's actually part of our vision statement for the ACC. It ends with the word outcomes. So we're going to hold the ACC and all of our members collectively, we're going to start to be more accountable for delivering outcomes, not just delivering the service, but what is the impact of that service? Let's dig into this. So two terms I want to separate, not to get too wonky, but when we talk about value, there's the value that we all generate for society, for our patients, for society, for the system. Then there's the value that the organization we work for generates for itself. More or less the compensation it generates. So we generate value externally, then we capture value internally. And generally, if you want to make more money, the idea is I want to capture more value. UW wants to capture more value. Generally speaking, to capture more value, a business has to generate more value. Now, there's some exceptions to that, but in general, over a long period of time, businesses that have their top line revenue growing, you can associate that growth with that business is generating more value. It's serving more customers. It's serving the customer's needs in a different way. It's delivering value and it's capturing value. We're going to focus for this discussion primarily on value generated. What we all together inside the enterprise of cardiovascular services, what's the value we generate externally? That's what we're being held accountable to deliver more value or to link our payment to the value that is generated. So let's look at the variables. We already know we're talking about VG, value generated, what we're creating externally. And then inside the red box are all the different definitions that comprise outcomes. So you could say outcomes, it's quality. We tend to think immediately of quality. There's also safety. Inside of every hospital, I was the hospital CEO. The big thing that we focused on was quality safety, and safety had a whole lot of measures, collapses, CAUTIs, et cetera, et cetera. Safety is an important element. So we have quality safety, then we have patient experience and patient reported outcomes. Then last, you can look at access and equity as an outcome. So when we talk about value, we're talking about we generate a value by delivering some set of outcomes. And the better outcomes or the more positive the outcomes are, the more value we generate. And last, we're going to talk about external cost. This is the price paid. So my cost to you, if I sell something to Eugene for $5, the cost to him is $5. Now my internal cost, whatever I sold him, let's say it only cost me $3 to produce that. That's my internal cost. So my internal cost is one element, but what Eugene cares about, he doesn't really care if it cost me $3 or $8 to produce. All he knows is he paid $5. We're going to focus on the relationship between what is paid for services, the price, and the outcome. We'll talk a little bit about internal costs because there is an element that connects to this. But primarily from a macro standpoint, society pays for a service and they get an outcome in return. And for healthcare providers, we kind of keep track of that. Sorry for the non-financial folks, but the way financial folks keep track of the value generated by any organization is the revenue. When we look at the financial statements of UW or one division of UW, they would say that division produced X number of dollars. That X number of dollars is a way of saying it generated that much value. So we keep track of value created by looking at the revenue, all right? Here's a basic formula. Value generated in healthcare equals all those outcomes as we define them over the price paid. And this started, there's a radiologist who used to run University of Utah Health Services, Vivian Lee. She developed the first definition of value. So she had value as quality plus service, how the patients perceive the service over the price paid. I've distilled that down to all those outcomes over the price paid. So all the outcomes from here, add them all up. I have positives and negatives. I divide that then by the price paid. If you are charging me a lower price for the same outcomes, I'm getting more value. If you're improving outcomes for the same price, I'm getting more value. If you deliver more outcomes for a lower price, I'm really getting more value. So you can start to see the association. But that formula, I think, is too simple. I think we need to add two more elements to this formula to make it work for the world that we're in and the world that we're certainly moving toward. One is time. As we all know, the bundled payments don't just look at the cost of that or the price paid for that one episode. They don't just look at what happens in that one episode. They have a time element to it. 90-day readmission, 6 months bundle, 1 year bundle. So we're gonna have to add time in. And more, we're defining the total cost of care, not just what happened inside the hospital. If I get patients out too fast in order to get length of stay down, I may have that patient more likely to return for a readmission in the next 30, 60, 90 days. If I do, then the total cost of care didn't go down, it may actually have gone up. I saved a day on length of stay, but I added 3 more days and $30,000 in cost 3 months from now, 2 months from now. Is that good for the system? Is that improving price? No, it's actually that's causing the price to be higher. So my outcomes actually, in that case, were not as good, and my price was higher. We have to start thinking about P, the price, in a more broad fashion, in a bigger window of time. What am I paying over time? But I think we're still missing one big element, and that is risk. If you get nothing else out of this rambling here this morning, I want you to understand the future has risk. To the extent cardiologists and the team and the health systems and the enterprises you all work for, eventually or now, are willing to take risk, those enterprises are going to deliver more value. If the enterprise says we don't want to take risk, then that enterprise is delivering less value. Let's take it down to a personal level. If somebody says, I don't want to take any risk, I just want to produce my work RVU, get my conversion factor, and go home, then I would posit that person is actually leaving money on the table, number one, but they're paying somebody else to take risk for them. And finally, I think that person is producing less value. That person is less valuable to me. If I'm the CEO of UW Health System, I would say the person who says to me, just pay me a paycheck, and I don't want to take any risk for the outcomes, and whether you get paid or whether we're succeeding in risk-based reimbursement, that person actually is worth less to me. Not worthless, they're worth less to me. All right? So I'm going to pay them less because they are worth less economically to me. So if somebody is willing to take a risk, then essentially they have delivered more value. So let's look at this. From an economic standpoint, if you say, again, I don't want to take any risk for the future success of my health system or my department or the Department of Cardiology or the service line, then you individually have diminished your economic value, or another way to say it is, you're paying somebody else to take that risk. You're producing more value, but you're taking some of the value you're producing maybe and paying somebody else to take the risk. I would urge you to not take such a passive view of your role in the future, especially with the cardiologists in the room who are looking at their 30 years of work future. Most of your 30 years is going to be in a risk environment. If you're not willing to personally step up and be accountable and take that risk, then I think your economic value could be diminished. So now let's put it all together. Value generated. There's value generated over some time period. Is the outcomes over that time period, the price paid for that time period, multiplied by a positive or negative number, the risk for that time period. So if you say, I want to take no risk, then you're generating less value. If you're saying I'm willing to take risk, you're generating more value. So this is the full equation. Now maybe I missed a few elements. We'll get some feedback in the questions. I've had some questions on this, but this is my presentation to you of the full value equation. You sit inside here, you sit here, you sit here, you sit here, or you touch on all three as an individual or as a team or as a service line or as a health system. Your personal compensation, let's just get personal. Your personal compensation, it could just be production-based. By the way, I really detest production-based compensation. I just don't like it. Full disclosure, hopefully health system leaders here that are here may not kick me out of the room. I just don't like paying cardiologists on a per worker RVU basis. I just don't like it. I think that minimizes the concept of the role that they play individually or as a team, but it's a common way. 90% of the cardiologists who are employed by health systems in the US, their compensation is 100% based on their work RVUs generated times some conversion factor. Then there's performance-based. Some percentage of the compensation, either the whole system or the individuals or the team, is set aside and tied to outcomes. And then ultimately, who's paying this? Are you paying yourself through your own efforts and work? Is somebody else paying it? And who's taking the risk for all the other elements? You're taking no risk for operating expenses. You're taking no risk for coding and documentation. You're taking no risk for efficiency. And again, my message would be no risk has less value. So finally, what are the ways to increase value? Look at this from a macro standpoint, again, looking externally to the marketplace, to Medicare, to the payers, to the employers, to the patients who are paying. There are 5 ways that we in cardiology could generate more value. We could help decrease utilization. We could pull out avoidable utilization. There's some effort around that, care models, post-discharge care, better ways of coordinating, remote monitoring, etc. We can decrease our price. This is a dangerous way, by the way, to improve value. Because if you decrease your price, and you don't decrease your internal costs, I learned in business school that your profits go down. If I lower my price from $5 to $4.50, but I don't do anything with my underlying cost, my profits get squeezed. So if you're going to lower your price, you want to do that because you've figured out a way to lower your cost. If you haven't figured out a way to lower your cost, it's a bad move to unilaterally lower your price. Now, sometimes it's forced upon us. Most of the time it is. Improve outcomes. So I can work on any or all of these outcome factors. I can take more risk, as I said before, or I can increase the time horizon, or I can do any combination of these. I can open up the time window. I can take more risk to the outcomes. I can put better outcomes. I can try to find a way to get the price down, and I can help you get your utilization down. Now that would be a home run. All five. I want to work with the health system as an employer who's helping delivering all five. So I'll end with this. What's the role of a cardiologist? So you can think your primary role definitely is a clinical role. There's no doubt about it. You're being trained to do a clinical, technical role using cognitive and procedure, other skills. That's good. That's the core. You need that. That's what you deliver to society. I would submit that that by itself, even though it's very valuable, it will always have value, by the way, no matter what kind of payment system we move in, that clinical skill set will always have value. So everybody take a deep breath. We're all going to have jobs. We're all going to survive. We're not going to go hungry. But how do I add more value? I think as you look at these other roles, this is an insight to your future of how you would add more value to your employer, the health system, and particularly how you would add value externally to those who pay for care. You've got to start thinking of yourself as a resource manager. What you do and how you do what you do impacts cost, the internal cost, the resources consumed. All right, so you're a clinical manager, you're an outcomes manager, you're a resource manager. Obviously, you interact with patients. There's some amount of patient experience that you manage. There's a lot of data that you interact with. So now you've kind of had, as a data manager, you're leading a team. And ultimately, I would say that the quality improvement, the efficiency improvement, the operational improvement of a healthcare system significantly depends upon the ability of that healthcare system to engage over a long period of time the physicians and their teams around quality improvement and efficiency improvement efforts. In the perfect world that I see, working as the CEO of the ACC, we would have all 35,000 ACC members in the US buckled up each day, leading their organizations toward quality improvement, cost reduction, better outcomes for patients, and willingness to hold themselves accountable by linking some part of their pay to the outcomes they generate. I'll stop with that.
Tim, that was a great presentation. Are there any questions from the audience? Dr. Otto. You always have questions.
Yep, great points. Let's get the engagement going. This is what I wanted to be here for, is to get the feedback. So first, on the first point, less than 15% of cardiovascular spending in the US is paid to the providers, clinicians of cardiovascular care. So I would submit that if we do nothing, as a bunch of cardiologists, the cardiovascular enterprise, if we do nothing, yes, reimbursement's getting ticked down, adjusted to inflation. My insight here is that as 15%, we're inside that 15%, as the 15% of the cardiovascular care, that's what we represent in terms of cost, we manage the other 85%. So to the extent we manage that 85% better, and I've seen this, I can show you kind of the formulas and the actual payment models, you can maintain and improve the compensation of cardiologists by not being paid for the CPT code, which is the 15%, but be paid for how well you manage the 85%. That's what society, that's what payers, that's what employers, that's what insurance companies, that's what Medicare is looking for. Who will help me deliver more value inside of that 85%? Taking pay cuts in the 15%, there's a little bit of marginal improvement that Medicare gets, but I don't think that's our value. Our value is not how cheap we can do our service. Our value is how well we can manage the 85%. That's number one. On the second point, I agree with you 100%. The PCSK9 guidelines that came out, what did they have in them 6 months ago? For the first time ever, they embedded cost. We are 100% committed. I believe it. I'm with you 100%. We need to associate. Every one of our guidelines needs to have an economic endpoint associated with it. NCDR, right now NCDR does not measure cost. NCDR is purely measuring quality or other related non-economic terms inside the NCDR. We are working to add external cost benchmarking to NCDR. So when you look at your NCDR report, it won't just be how good of a job you're doing from a quality standpoint, it will also be how good of a job you're doing compared to the cost, external cost. So I agree. We need to add cost. Every guideline needs to have cost. Patogary is the chair of the guideline committee that we have with the AHA that has already been recognized. That is a big plus that we add cost to guidelines.
Were priced 100 times higher than our peers in Europe. And so it isn't that, and all of the things about taking risk and everything is about reducing services and finding efficiency, which is only 50% of the total problem. And but we have all these middlemen who are gaming the system. And so if we don't get rid of that, then we'll be more efficient and we'll still have middlemen gaming the system. Increase prices by 100%. And so what are we going to do about that?
So when you refer to the middlemen, are you referring to the PBMs, RBMs, or the insurance companies? Which one? Yeah. So I think in all of those areas, what we need to focus on are the things that are most under our control. So I agree, we need to put pressure, and I think we as the ACC, we as society, you as taxpayers, you as voters, put pressure on those things. I agree that the PBMs and the others who are in this middleman world, they don't add a lot of value. So we can attack those, we can push those, we can point to those, we can highlight those. But I would also say that inside of all healthcare services, there still is an opportunity for more efficiency that we are more in control of. We can't control much about what a drug company charges for a drug. Now we can indirectly do it through the guidelines. So this is Dr. Otto. So Dr. Otto's question, look, what happened with the pricing of the PCSK9 drugs after we issued our guidelines? Anybody recall? Every one of those companies dropped their price. Every one of them. Now I would say the ACC, you as ACC members, me on your behalf, that gives us a bully pulpit to address one of the points you're making. We need to put pressure on the drug companies. I think we need to put pressure on the RBMs, radiology benefit management companies. We had the 3 major RBMs at Hart House a few weeks ago to talk about pre-authorization and the nonsensical approach that they take to pre-authorization. We had United and Cigna and other major payers there. So we're trying to engage in a dialogue at a macro level to deal with some of those unnecessary middlemen. So it's a long haul. I think we need to put pressure both legislatively and then politically and then publicly on that, and use your own personal clout. Couple that, though, with things that are under more our direct control. And what I have learned 30 years working inside of cardiology, working with a lot of smart cardiologists, and I asked them, this patient came to the hospital today from a nursing home with CHF exacerbation. Was this admission, which goes to the ER, the ED calls the hospice calls the nurse practitioner, write the admitting orders, $20,000 later, patient goes back to the nursing home. Was that admission avoidable? And everybody looks at it and says, yes, under a better care model, for less cost, we could have kept that patient out of the hospital. What's missing? The payment model doesn't align with it. I think that's true, and we need to be advancing that payment model. I also say, take this in the spirit that it's given, we need to stand up and lead the discussion. I see too many cardiologists that are passive inside their health systems or passive inside their markets saying, well, somebody else is controlling this. I actually think we have the ability together to have more public comments, more position statements, more white papers, put more pressure on the system, including Medicare and your local payers in your own state. So I think we can be more active and lead this discussion.
And all these things are only 85% versus the 50% prevention and the outpatient drugs which we do. But if are we seeing the same thing on all of the hospital related stuff that we don't have any control over?
It's a great point. I would say you do have more influence, less control. Let me give you a couple examples. So on the point of how much more we pay, we easily pay 3 times more for the big boxes than Europe pays. And the reason why I know that is in my former life, back when I was running the South Carolina Heart Center, I was the guy that, with Michael Kuhn, organized the Society of Cardiovascular CT. I have a deep passion about cardiovascular CT. I'll save that for another discussion. But at that time, if you remember, the reimbursement for cardiovascular CT, coronary CT angiography, came out very low. Came out high originally with the T codes. Then when it got a permanent code, it was low. What happened after it got that low permanent code? People who wanted to get into the coronary CTA business, they went to Philips, Siemens, GE, Toshiba, now Canon, and said, we can't afford to pay as much. What did all those companies do? They lowered the price of those machines. I remember the first coronary CTA machine I bought in South Carolina, 64 slice. I bought it for $500,000. The list price was 1.5. I probably could have got it for $250,000. That's what I was doing to get the best price. The point is, the price for the machine is a function of the reimbursement of the service. The reimbursement of the service falls, you'll see the equipment companies adjust their price. On the final point though, I think cardiology, particularly those who get more informed about the cost of these input costs, actually can have a great influence. I've seen it. I've worked with my cardiology groups that I was the CEO of, the service line leaders, the last hospital that I worked at as the CEO. When you engage the cardiologist around all these input prices, I can recall several meetings. These are beautiful meetings where working with the cardiologist, and they're lined up, there's Abbott. They look the Abbott people in the eye and say, unless you can get your price for the stent down to this amount, we will not use Abbott stents. Every time I've been in those meetings where the cardiologist was that crisp, I guarantee you what the outcome. Abbott lowered the price. Medtronic lowered the price. The prices came down. But if I tried to do that as the administrator or a service line leader or the CFO or the supply chain people, you don't get the same effect. So you are critical to input pricing coming down. You actually probably don't even know how much money, how much juice is in that lemon. You squeezed it hard enough, there's a lot of value there. That creates value for UW. That puts you in a position where you're leading that change. Fair enough. I agree. That's a good point. Okay. So to do that analysis well, you would have to have access to claims data to look at who are the patients that are driving a lot of cardiovascular spending in the US. What you'll find, what I found, is primarily the dual eligibles. Patients who are on Medicare primary, Medicaid secondary. You would be surprised as to how much poor fragmentation of care there is, because those are patients that a lot of people don't want to take care of. So it may actually be the inverse. It may be the patient population that's not very attractive that actually holds the biggest financial benefits. If you look at ACOs around the US, the accountable care organizations that have taken risk, they do better on dual eligibles than anybody, because inside the dual eligible population is kind of a low-hanging fruit of poor coordination, other issues that you can address. So yes, I think there are opportunities to make certain procedures or certain episodes of care more efficient. But I think the biggest opportunity for avoidable costs sits in the chronic disease populations, particularly the elderly and poor. We're spending a lot of money in the U.S. on dual eligibles. It's an amazing amount. For a typical heart failure patient, between Medicare and Medicaid spending for a typical heart failure patient dual eligible, we're spending about $40,000 a year per patient for cardiovascular problems. A lot of ACOs have looked at those populations and have gotten that cost way down by better coordination. So I think if you were to get the claims data, put your cardiology hat on, get the claims data and start looking, you would see, wait a minute, there are opportunities with patient populations that heretofore I wouldn't have thought of as very attractive patient populations. Sure. Yeah. Yeah. Yes, if I was the czar of healthcare, which I'll never be, but if I was the czar of healthcare, I would have 3 different populations of patients and 3 different payment models. For elective procedures, I would bundle those. For chronic disease populations, I would do a population health, tie it to a year of management. Third category are your TAVRs, your ECMOs, your Impellas, your transplants. Nobody should be held accountable for the risk of that event happening. So if the event happens, the provider should not be accountable for the event happening. But the provider could be accountable for the episode management. But I would say some of those patients are so complex and the variations in care or the variations in outcome is so wide that you shouldn't hold any physician or health system accountable for those populations. Provide the service to the best of your ability, which is what you should do. But there's too many other factors and too much uncertainty around those patients to take a financial risk. So I would not bundle for population health that segment of patients.
So I think going from 3 people to 20 people to 70 problems over the last 50 years seems to be like excessive care. Great, okay, even though I was a patient. Very little is been said about population education diseases. And I think if you look at the Seattle Times, you hardly ever see anything in the healthcare part. Hardly ever. Maybe once a month if that. We talk about care and cost, what people can do about make their lives better and more healthy.
Yep.
Now, the other thing is, I think behavior-wise, I think we need to also, people who smoke, I think they need to have a higher price for care. They need to have some kind of penalty to drive them away from the bad things.
I agree.
We need to do that. And I don't think if we don't control that, I think all the things we recommended will have some effect, but I think in the long run.
So I'm glad you brought this up because each time I've given this presentation or some form of it, somebody in the audience has asked this question about the patient accountability. And how do we factor that in, or should we factor that in to this overall equation? Because right now, the patients have the least amount of risk of all in some cases. They are paying co-pays. Let's face it, the Medicare patient pays a low amount out of pocket compared to the financial value being received. So how do you link their behaviors or not complying with the regimen of therapy or not doing the things they should be doing to improve their overall health? That's a hard one to figure out. I don't have an answer to that. I agree with you in terms of the modifiable risk factors, whether it's smoking, obesity, whatever it is. How do you link that? Some health plans have started to do that. Where I worked before as the hospital CEO, we charged smokers more their health insurance premiums than non-smokers. Then eventually we said, we're not hiring smokers. That was the big aha. Yeah. Yep. And I would say on that one that because of the unique role that the tertiary academic medical centers play in the U.S. by region, that some of these formulas or some of these approaches will not work in the optimal way. However, with that said, if you compare, this is something that we're starting to look at inside of NCDR, compare all academic medical centers like UW to other centers around the country. You will see significant variations, even in significant populations, you'll see variations in the cost of care. So there still could be an opportunity for better coordination of those patient populations or of those episodes of care. Otherwise stated, I'm not convinced that we're at Vmax efficiency, even inside of the tertiary centers in terms of how they're managing those populations post-discharge. Sure. Yep, all good points.
I think we have one more. Dr. Kilpatrick has been very patient. Back.
Well, great, thanks very much. But I wanted to ask you how palliative care could work into all of this stuff. And part of the reason I asked is sort of the great hope was that we could talk people out of VAS and ECMO and everything else. But the studies have really not shown that. People have better quality of life, and they thought that palliative care investment was great, but they didn't actually use services much and decided to go out to hospital more. So how do you see this kind of playing into this larger sort of dynamic? With that kind of outcome, I'm sure we're going to get more payment for palliative care. But what do you see the role?
So when you said that, yeah, you're not sure you get more payment for that value, what do you mean by that?
I'm not sure people are going to support in palliative care. That might be a person people into the field more often, unless we can show sort of the traditional value component, or at least live up to what everybody hopes they would do. But it seems like it's still a vitally important thing to look at different transportation.
Yeah, I would say if we move into, where's the, sorry, going backwards right here. If we move into this category of payment, where we have population-based payment, then I think palliative care, obviously at that point, has a more direct economic value in that it can help manage and deal with patient populations without having to do the expensive interventions. Otherwise, if you're still primarily a fee-for-service world, even this, where you bundle, it's still fee-for-service. You put risk in it, but you don't get paid if you don't provide the service. Whereas in population health, you actually get paid for managing a population, even if you don't do ECMO, Impella, TAVR, et cetera. So palliative care, I think that's a great question. I think it's going to be harder to fold that in as long as the incentives still work for episodes. Let's face it, if you're in a bundled payment world, your incentive is do more bundles. It's a great point. Maybe it's something we ought to research inside of cardiology. What is the role of palliative care in cardiovascular disease management?
All right. That was a great discussion. I think